Hello, my name is Alice McGill. I'm a physician assistant at Penn Urology, and this is my lecture on urology. Sorry I can't be there, you guys, and hopefully you guys are staying safe out there. But this is it. This is the lecture. So as we begin here, this slide here is just your typical urinary tract system. On the left there is your male, on the right is your female. A big difference is, of course, the absence of a prostate in your female patient. So as you can see there. Familiarize yourself with that. Just make sure you make a note of that. So the first slide here talks about your bladder disorders. I'm going to go through all of your types of incontinence that we generally deal in urology. Of course, first here it's defined as an unintentional leakage of urine at inappropriate times. Of course, this is very predominantly found in women. Women will report this. Usually it's often associated with after childbirth and age. It's a specific type of incontinence there. As for men, it is often a manifestation of an enlarging prostate, which we'll go into more details later in the slide. So here, the first type of incontinence is your urge incontinence. This is typically seen in someone with a detrusor overactivity. My understanding is that you already have the lecture for pathophysiology, so I'm not going to go into much detail of this, but just know that this is typically a detrusor overactivity situation or problem. In women, it's usually a very intense urge to urinate and it cannot be stopped. So this can happen anywhere, in their car, as they're standing. It could be a very sudden sense of urgency and they can't make it to the bathroom. Same in men, but usually these are associated with symptoms of urinary obstruction. So for instance, they will claim that they have a very strong sense of urge, but then very slow to eliminate. And these are the guys who will claim, weak flow. They feel they don't empty their bladder as often or as quickly, and they will complain of increased frequency. So just think that, if there is any abrupt onset of these symptoms, especially with any perineal or suprapubic pain, or even hematuria, blood in the urine, it does require an investigation with a cystoscopy and a urine cytology. So refer to your urologist if this is the case. Now, with urge incontinence, the treatments typically is bladder training. You want to start avoiding schedules. So these are people who usually will say that they're avoiding, every 1 hour, and it's bothersome. And so we try to train them to hopefully go, increase it by 30-minute intervals per week, so that they increase their time in between their voiding. So hopefully the goal is to get them to about 2.5 to 3 hours before the need to void again. Big lifestyle modifications are recommended for these folks. Usually, caffeine is a big trigger. And of course, weight loss is definitely recommended, especially in a very morbidly obese patient population in both male or female. Now, there are definitely medications you can try. The most common class is your anti-muscarinic agents or your anticholinergic. It's a big umbrella for all these medication. And the two popular generics that are available out there is toltolerdine, which is the generic for your Detrol, and oxybutynin, which alone itself is already generic and available. They both come in either short-acting and long-acting. And remember, these are the anticholinergic class, so they're going to have very common side effects of dry mouth and dry eyes, especially in older population or older patients. You get delirium. And a urinary retention is a very common prevalence with this medication, because remember, it decreases your urge to urinate, so therefore it can lead to urinary retention or the inability to empty after a long period of inactivity. Typically, your long-acting agents are going to be better tolerated. The next class of drugs is your beta-3 agonist, which is usually Myrbetriq, which is very expensive. It is not available generic yet. It is a very great medication if your anticholinergic therapy fails, or if the patient reports a lot of adverse side effects there, or adverse drug reaction. So consider this as a class. The last one here is, you would definitely refer to urology for this, but the Botox injection, which is becoming a little bit more popular with urge incontinence. And also with folks who have overactive bladder conditions and interstitial cystitis. This is usually a typical treatment route that we will try, but it was recently FDA approved, so it's becoming quite popular as far as treatment. And usually people who are candidates for Botox injections are going to be the people who are, urgency frequency is very bothersome and they failed all medical intervention. Know that this is a high risk factor for men and women because it does lead to urinary retention. It is that effective where it actually will not allow the bladder to eliminate. And so these patients do have a tendency to self-cath for quite some time until they actually get the sensation back to their bladder, which can take almost up to 6 months. But again, it is Botox injection, and it does lead to a very high incidence of patients self-catheterizing themselves. So CIC is clean intermittent catheterization. Okay, so it just is a nice little chart I found online that kind of breaks down your anticholinergic. So any pharmaceutical buffs out there who are a big fan of knowing the ins and outs of medication, just know that most of the medication that tends to act on the bladder are going to be your M1 selective or your non-selective group of medication. Some of them do have or generally fall into the first two category there. Okay. So, second type of incontinence is your stress incontinence. Pretty much the very most common complaint in women. Let's see, urethral incontinence there. Basically, it's a urethral sphincter that is non-functional or weak. It is definitely the second most common in older women and first most common in men after a radical prostatectomy. Loss of urine happens with increased intra-abdominal pressure, such as laughing, coughing, and sneezing and lifting. So if you ever heard the expression, don't make me laugh, I'll pee myself, this is it, guys. This is it. Generally, the treatment for this is going to be your pelvic floor exercise or Kegels. Usually a pessary or vaginal cones are more for female patients who have a uterine prolapse noted on their gynecological exam. This is something that usually either a urogynecologist or gynecologist can place. A general urologist usually will not handle this. They usually are referred out to more of the female provider or female specific experts. Of course, if all else fails, if they fail the pelvic floor therapy, Kegel, and pessary cones, it just doesn't work for them, then surgery is an option. So sling placement is the most common surgical option for these patients here, both in men and women. There are artificial sphincters. I didn't put that here. It wasn't indicated in the book there, but in our practice here, we do a lot of what we call artificial sphincters. So it's something that's generally introduced to actually mostly men, especially after a radical prostatectomy. It's just a little tidbit there. Now, as far as your other types of incontinence, one here that they talked about in the book, they refer to as like leaking that happens because of obstruction. Usually this is noted as dribbling after voiding, most commonly seen in men. So these are men who will empty at the toilet, but then they'll go to zip up, and then they'll indicate or report that they feel a good half a teaspoon of urine dribbling out of their penis. Usually the cause for this is typically an enlarged prostate. Your book says cancer. I put in parentheses there, not really. Most men who present with prostate cancer are usually asymptomatic. The enlargement of the prostate is a benign process, so that's why I wrote there cancer, really, not really. But your book says so. So there, I just a little disclaimer there. As far as bladder neck contractures, so this is at the site of where your bladder meets the urethral sphincter and after a radical prostatectomy. So this is something that is very unique. This happens because of scarring and a narrowing of the bladder neck at that junction. And so a lot of men will report a sense of urgency and frequency, and they do empty, but then afterwards they will, because their bladder is finally relaxed and their sphincter relaxes too, they actually will dribble after they feel that they've completed their stream. Urethral stricture is something that can happen that's seen trauma to the urethra, whether it's through catheter placement or removal, instrumentation like having a scope pass up into the urethra, or their prostate itself. Their prostate is actually restrictive to the urethra. So just things to consider in both male and female, specific prostates, of course, for male. Of course, stones is the other obstruction. If there is any kind of obstruction within the urethra or bladder itself. So bladder stones and kidney stones is a consideration. Now, As far as the treatment for this, usually you have to find out what the underlying cause is. Usually, if you do not treat it quickly enough, or if there's a progression of symptoms, it tends to lead to urinary retention, where they have the inability to empty their bladder, which can lead to hydronephrosis, which is that swelling or fluid collection or buildup in the kidney. And this is generally seen, or usually will prompt a kind of an ultrasound or renal ultrasound if they complain of flank pain with acute onset of dribbling. So again, a lot of acute settings here. Now, in an enlarged prostate, so these are guys who have chronic dribbling afterwards, no issues with hydro or urinary retention, definitely want to consider medication like an alpha blocker or finasteride combination. But typically, surgery is most effective, especially if failure with medication. Now, if they are a non-surgical candidate, you really need to consider discussing leaving an indwelling catheter versus having a clean intermittent catheterization, so having them self-cath. Conditions for an ideal self-catheterization is if the patient is confident and feels comfortable enough to self-cath. In men, it's usually about, I would say, 50-50, depending on how large their prostate is. I would say that my success with guys trying to get themselves to catheterize themselves is about 50-50. One is they tend to be very hesitant once they feel resistance and they pass the catheter, and so they don't want to really push further past that. And so when they do that, or if they feel that, then it's smart. We don't want to attempt it. So at that point, we usually consider leaving an indwelling catheter, and they come in for their Q4 to 6 weekly changes. So again, lot to consider here in urology when you send them over to us from a primary care setting. Okay. Now, the other type of incontinence, which is overflow incontinence, this is actually pretty, I would say, common in men and women, more so in men as they get older and women too as they get older. The big reason here is detrusor underactivity. So causes for that would be chronic obstruction of the bladder. So usually idiopathic is something, of course, there's no rhyme or reason for this. The other one is the sacral lower nerve dysfunction. And so you see that more with people who have spinal cord injuries or some type of a neurological disease such as Parkinson's or stroke. These are people, men and women, who really report that they barely feel the sense of urination, and they maybe just make themselves go just because they know they need to go. But then they'll leak because then, if they haven't emptied recently and basically think of a very full bladder and it tips over and it overflows itself. And that's pretty much what it is. It's a full cup or a full bladder, and this excess urine is leaking out. And so that's what they'll complain about, is this excess urine that leaks out. And usually they'll report that they don't feel the urge to urinate. And this is something that is concerning, because it can lead to urinary, of course, retention, but then also backup flow into the ureters and, of course, into the kidney. So generally, you want to scan them right away with a renal ultrasound and a bladder scan. And should the bladder volume reveal anything over 450 with signs of any hydro, they should be catheterized immediately. Usually these patients come to see us, and generally we talk about time voiding if they can get any type of bladder activity. If they really have, if their detrusor activity is completely shot, and that's usually done through testing, like with the video urodynamic testing, or VUDS as we call it. And if their bladder is completely shot, then these are patients who are going to be chronically catheterized or having a chronic indwelling catheter. So this is usually the end result or final or kind of the late stages of treatment for this. Basically, we just want to prevent them from having any type of renal failure, renal function dysfunction because of their hydronephrosis. Now, here is your reversible types of incontinence. So these are things that you tend to kind of rule out, or at least treat accordingly based on what they're coming to you with. So the acronym here is diapers. I just recall when I was in PA school myself, about more than actually 12 years ago, or 10 years ago, sorry, that the acronym for us was called DRIPS, DRIPS, very appropriate there. But here it's diapers, and as you can see, D is for delirium. So usually delirium that leads to incontinence is, loss of they lose their sense of motor function or of their bladder function. And so you want to treat the cause of their delirium, which led to their incontinence. And usually, if it's an elderly patient, think of infection, and if they're in the hospital, try to get them out of the hospital. Those are going to be the underlying issues there. Of course, eyes for infection, your UTI, urosepsis. This can definitely lead to some type of incontinence. For our female patients, atrophic urethritis vaginitis is, I think, very common and very reversible. Generally, they are considered usually a topical estrogen agent is recommended in this case. We do not prescribe this in urology. Generally, this is referred to the gynecologist for this. Of course, it has its own risks and benefits of topical hormonal therapy. So that's something I'll defer to your gynecological lecture. Some pharmaceuticals, these are definitely contributing factors for incontinence, especially your diuretics that will lead to definitely urge incontinence. Your anticholinergics, this is kind of the opposite, which will lead to more of like an overflow incontinence. So remember that latter risk of urinary retention and not feeling the urge to urinate and having it overflow. So there's your incontinence there. Some psychotropics can definitely cause, urge incontinence or stress incontinence. Opioids for sure. That's usually, delayed sensation, delayed reaction. Your alpha blockers in females, so that's like your Flomax and your Terazosin. So all the Zosins that you remember from pharmacy or from pharmacotherapy, those are the ones you want to avoid in females. They lead to a increased urge or frequency incontinence. And then you have your alpha agonist in males. So those are your decongestants. So that's a big family there. Actually on the box, if you read aloud the decongestant medication warning signs, they will say if you are a male and you have BPH to avoid the medication because it will lead to what we call urinary retention. And so that's usually quite terrible for the guy. So just kind of keep that in the back of your mind when you're trying to prescribe medication. And of course, your calcium channel blockers. Of course, the big fix for this is change and avoid these meds if you can, if possible. Now, there's going to be psychological factors. So people in very severe depression, these are patients who do not want to get out of bed, so they will void themselves. So, it's kind of is this truly a real incontinence issue? But they will not come out and they will pee themselves and wet themselves, soil themselves. Psychomotor retardation, so this is they are physically unable to even get to the bathroom. So unfortunately, I see this a lot in a lot of nursing homes and nursing home patients who come to see me in clinic. They're either diagnosed or complains of some form of incontinence, but when they come in with usually their aide and I interview them, I tend to find that it's because they have a lack of access to the bathroom and so they will wet themselves. So, but yeah, so that's unfortunately a separate fix, but consider that in a lot of these issues here. Excess urinary output. So again, maybe due to meds, for instance, your diuretics. Are you overhydrating? Patients drinking 4 or 5 liters of water, that will definitely increase your urge and your sensation to void. And is there any metabolic disorders like your diabetic patients who, complain of being thirsty all the time and so they constantly drink water all the time? Their nighttime urination is disrupted because now they're waking up. So consider those as issues or causes or onset of these incontinence issue. And of course, restricted mobility and immobility, again, same thing with our nursing home patients, hospital patients, hospital beds. Are they just not really able to access that bathroom? And so easy enough for these patients, provide them a urinal and bedpan. So especially if they're in the hospital, it's going to be a urinal or bedpan for them. Okay, so here, some clinical pearls. This was not in anything anywhere in your... Here we have our bladder condition. So overactive bladder is a big one. Just know that everything that I mentioned under urge incontinence falls under the overactive bladder. I can go on a separate lecture about overactive bladder, but that's like another hour to 2 hours of discussion. But this is something that generally in a primary care setting, these are patients who really fail on a lot of the first line therapies like the anticholinergics, and they're desperate, and so they're coming to see urology to see what they can do for this. So that's usually the patients who consider that Botox therapy. But just know that overactive bladder can be very mild to very severe, but it's basically a very type of urge incontinence. and it's a nerve dysfunction. They're a detrusor overactivity again. Of course, you have your type of prolapses here. So I meant to write in your ureteral seal. Sorry, that's the one picture on the left there. I'm sorry, these are both cystoceles. Sorry, I didn't find. There was no indication that I actually put in ureteral seal, so ignore what I just said. This is specifically a cystocele. So this is a bladder that has dropped into the vaginal canal. And generally, if you're doing any type of vaginal exam, just to see if it's there, it doesn't require a speculum. You just basically use 2 fingers, push down on the posterior part of the vaginal canal, and you'll see that cystocele, that grade there. And so in your picture on the left, that's I think roughly about a grade 1, a grade 2 cystocele there. And of course on your right there you have your kind of demarcation of what's no cystocele, what's normal, and then grade 1, 2, and 3. My biggest takeaway is from a primary care setting is just to know what a normal vaginal canal would look like, in a sense of, there should be no prolapse, or vaginal or cystocele prolapse or rectocele and that type of thing. So just know what normal looks like, and then from there you'll be able to find, hey, you'll see something hanging off of the vaginal canal, especially the anterior canal there, and it drops into your space of view, then you know that that's a cystocele. And usually, if you actually push on it, you can actually express urine from it. So, and a lot of women will do that if they're kind of very persistent about why they're leaking. They'll come in and they'll tell you, or at least they tell me, that when they pee and after they've peed, they still feel like they have to go, and they can feel something like in pressure, some kind of pressure in their vaginal canal, and they'll press on it, and then that's how they can get more urine out. And so they'll tell me that. But on your exam, you can do the same thing. You can just actually gently press on it and push on it. And if you feel it's quite fluid, you'll express urine to the urethra. And in that picture on the left, that black cord there, that's actually the urethra right there. So that's a catheter that's in place there. Okay. All right, so interstitial cystitis. This is something that was, I think, mentioned in the book, but very briefly. This is something that was on your, I think it's on the PANTS blueprint. But just know this, that the cause of interstitial cystitis, no one knows for sure. This is typically a diagnosis of exclusion. You are not doing this in the primary care setting. This has to be done in a urology office. You are referring to us if all conventional workup reveals nothing. These are patients who, sounds like they have urgent incontinence, sounds like they have stress incontinence, and they're bothered by it, but then there's pain associated with it, which then makes you think it's infectious in nature. And so you'll do the workup. You'll get the urine culture, and a urinalysis and all of that, and give them the empiric treatment for an antibiotic. But then they'll come back and then they'll say, I still have these symptoms. It didn't work, even a few days after taking the meds. And then you'll see that, of course, the urine culture is negative. So, of course, the antibiotic treatment won't work. There was nothing there. But just know that these are patients who really have quite a workup panel, and all comes back negative urine culture, imaging, and even a urine cytology, a urine or cystoscopy, which is a bladder scope, and even a bladder biopsy, negative, no findings of anything. So generally these are patients who are then labeled interstitial cystitis. So I know each kind of profession, or each site has their own type of kind of blanket diagnosis, and this is ours here, interstitial cystitis. So it is a very unique area. Again, this is something that we can lecture on, that we talk about at our conferences, and it's becoming more and more prevalent. So as we start to talk about more autoimmune conditions and disorders, could that be a contributing factor? Nothing is ruled out at this point, but just know that the causes is still unknown, and so a lot of the therapies out there are usually either about 30 to 50% effective. So that's what's being reported in a lot of the urology conferences that I've been so far. Very hard diagnosis to treat and follow, and but again, this is specifically in for urology. I believe on your boards, I think the big thing is the question for this is, if I recall from the last time I had my board, was the referral, was when do you refer, and it was a patient, it was a patient scenario, and the workup was negative, and I think the answer was to refer to a urology specialist regarding this diagnosis. So that was my answer for that board question. Hematuria. So this is a very pretty much the about 25% of my practice outside of what I do for my attending physician. This is basically defined as blood in the urine. It's either gross or microscopic. You really need to consider the source of where this blood is coming from. So is it coming from your upper tracts, like your kidneys and ureters, versus your lower tracts, your bladder and your urethra? So if it's in the upper, this usually accounts for 10% of the causes. And generally, an active stone accounts for 40% of these 10% patient population. And so not just blood in the urine will be present, but also complaints of flank pain, maybe fever if it's a very obstructive hot stone, infected stone. But stone is going to account for about a good chunk of these guys. These patients, sorry. Now, medical kidney disease. This is generally for your glomerulonephritis type of disease. There, generally, that's sent to your nephrology. They usually complain of not bright red blood. Those patients usually, if they complain of any type of cola color blood, like brown blood or brown urine, I tend to lean more towards is metabolic. So I'm going to send them to nephrology for workup. And getting a urine micro and a urine cytology and does not hurt either, because you'll see protein in the urine, and that's a big indication for them to really see the nephrologist. Now, renal cell carcinoma and urothelial cell carcinoma cancer, of course, is the biggest concern here when we see blood in the urine. So that's something that, of course, needs to get worked up. Of course, the lower tracts, you have your most common source is usually bladder cancer, which is why it's taken seriously. BPH is considered if the workup is negative, if there's negative urology workup, such as a negative cysto and urine imaging and so on. And of course, active kidney stones can still produce blood in the urine, and you can have kidney stones in the bladder and the urethra that can cause blood in the urine. So just consider that. Urethral stricture and urethral prolapse. Urethral stricture more because of, again, if they had a catheter in or if they had any type of instrumentation. And your prolapse in women, sorry, I got cut off there. But this is going to be for women who have pretty much it looks like a kind of a donut around their urethra, and they feel pressure at the tip of their meatus and when they pee. And so that's where they'll complain of seeing blood on their underwear, and they're not menstruating. So that's something to very quick and easy exam to look. That's where I meant to put a ureter because that's what that is. So I do apologize for not putting that picture up for you guys. Now, definitely you in a primary care setting, you must refer to urology to finish this workup. We have to do the workup for this, and we have to do it for the new indication now. And so generally in the past, it was you need to have 2 consecutive urine micro to kind of basically initiate the urine, the cystoscopy and the CT urogram, the imaging. But now the AUA guideline has actually changed that, and so it's any known history or 1 positive urine microscopy. So not a urine analysis where it's a dipstick and you see blood in the dip. You have to send the urine out for a urine microscopy, and then of course a urine culture, because if the urine culture comes back clean and you still see blood in the urine, it's going to lead down to that investigation. So just know that these are patients who have a positive red blood cell count on their urine microscopic exam. Now, any asymptomatic hematuria with confirmed urine microscopy of 3+ red blood cell per high power field, usually without any recent instrumentation. So they didn't have any kind of procedure, requires an investigation with a cystoscopy, which is a scope into the bladder and the ureters if needed. A urine cytology, which I know in your book it actually does not indicate that, but we order that in our practice here. And a CT urogram is a definite, or some type of a CT imaging that has it's basically a timed imaging release where they inject the dye and then they go and they capture in phases as it filters into the kidney, ureter, bladder, and your urethra. So it's very specific CT scan. It's garnered towards the kidney, bladder, and ureter. So you definitely want to get a CT urogram or pyelogram. So just know that you're getting this in all of them. We're doing this in all of them, especially if that person has any history of smoking where they quit recently quit or quit a long time ago, but any smoking history. This is a very high risk for bladder cancer patients. So we'll talk about that in the bladder cancer section. But currently, if the workup is negative, there's no lesions in their bladder after a Cisco, CT urogram is negative. They don't see any lesions or abnormality or any kind of protrusion or projection from the bladder, ureter, or kidney, but they still have persistent microhematuria on a urine exam because they get their urine, it's seen on their preventative exam. Then they will need to go through this whole workup process again every 5 years. So just know that now there's more of a persistent, or I should say a screening exam now, kind of very similar to like a colonoscopy. So it's become a little bit more aggressive as far as surveillance with hematuria and bladder cancer. Now, this is an example of a urine microscopy lab, so I just want you to just be familiar with this. Now, the pus cells here, on most labs, it'll say white blood cells, so it's white blood cells per high power field, HPF, sorry. Red blood cells, here it is what you want to see. So generally, the lab results here, this is just for someone who was their urine microscopy was fouled while they were in the hospital. You can ignore that, but I just want you to look at your reference range here. So it's whatever your reference range is considered normal, and that's what you go off of by. But by definition of what is positive, regardless of where the reference range is, it's 3 plus. So 3 plus red blood cell per high power field will be an indication to see a urologist, and they will need to go through the workup. Okay. Here we go. So signs and symptoms of irritative voiding symptoms such as frequency, urgency, and dysuria. These are patients that are going to complain of increased urgency and frequency, burning with urination, and bladder discomfort, like suprapubic discomfort. And specifically the burning sensation, they feel it all throughout the tip of their meatus all the way into their bladder, so male and female. And what they'll complain mostly is at the end of their stream, there's this very sharp pain, and they feel like they have to go again within seconds to minutes after just finishing their stream. And so that's a very common symptom or complaint. Of course, signs may include gross hematuria and, of course, a very cloudy urine upon inspection. Your lab findings, especially in the office, if you do a very quick UA just to really confirm what you suspect and send out to culture, it'll show possibly positive white blood cells, nitrates on there, and blood, even plus or minus some positive ketones. But just know that if the urine is extremely bloody, it will obscure your urine analysis results. So always order your urine culture. That will give you your organism and confirm if whatever empiric antibiotic you're putting them on, it will be susceptible to it and treat them. Okay. Now the treatment is usually once you have that urine culture, go ahead and treat them. As long as you got that urine sample, you can put them on any type of empiric treatment. Generally, it takes about 72 hours to result the culture. Just know that you want to avoid fluoroquinolones as the first line. That's what your book tells us. But just remember, if your first line fails or is resistant in your neighborhood or in your area, then you want to use you can go ahead and use your fluoroquinolones, which is going to be your Cipro and your Levaquin. But generally, Bactrim and nitrofurantoin or macrobid is usually your first line of choice. As far as kind of to minimize their symptoms of that discomfort when they pee, especially when they're urinating, that burning sensation, that pain, you can give them a Pyridium or Azo Standard, which is over the counter. This is a type of bladder analgesia that helps with that. Just know that infection in men is rare, and so you have to consider other pathological process that's causing their infection. So the book talks about uncomplicated UTI in men versus complicated UTI. The rule of thumb in urology is there's no such thing as uncomplicated UTI in men. All UTI in men is considered complicated, and that's how we approach our men with a positive urine culture. We're looking to find out what is causing them to have a urinary bladder or a positive urine culture. Now, if there is persistent or relapsing UTI, so these are patients who have a positive urine culture after they've completed the therapy, and or if they complain of recurrent UTIs or a UTI that happens again, usually about more than 2 infections in 6 months, or more than 3 infections in over a year. So these are patients that need to be referred to urology because we do need to kind of work them up to make sure there is no anatomic abnormality, such as a bladder fistula or diverticula, or stone disease. A lot of times bladder stones and kidney stones, more so bladder stones in men, kidney stones in both men and women. And then, of course, if they are retaining any urine, it's leading them to have this chronic infection, especially the people who are relapsing or with their therapy because they're showing the same organism over and over despite being on antibiotics for 2-3 weeks at a time. So consider that. Okay, so acute pyelonephritis is basically a bladder infection that's now leached into the kidney, and so this is pretty emergent. A lot of the complaints are associated, these are same complaints of a bladder infection, but now they have fever and flank pain, and so these patients need to be referred immediately. Generally, they're going to be referred to ER. They need to have an IV antibiotic initiated, and they need to stay and receive that therapy for at least 24 hours, and then they'll be sent home with about a 7 to 10 day course of antibiotics, oral antibiotics. So these are patients that are very, very sick. They're basically on the doorstep for sepsis. So if you see this, so any bladder urinary symptoms, and on top of that, with fever and flank pain, they go to the ER. Right here I wrote urology, but again, because it went to the kidneys, they eventually will end up being referred to the urologist after they get discharged from the hospital because they need to find out. We need to find out if what led to their kidney infection. So the biggest one is, in this case, we'll look for basically a stone. Stone is a big cause of this, and then of course, if there is no stone and this just happens to be an acute process, usually the patient resolves and recovers pretty quickly from this, substantially. So just some, I like these charts. This actually came from your book. This one here is your first line therapy for acute cystitis. Pretty much hasn't changed in the 10 years I've been practicing in urology. So this is pretty standard here. Okay. Then you have your other, same thing, it's also in your book here. Sorry about the very small font, but just to be aware of the treatment here. So as you can see, for acute pyelonephritis, they need to be on IV antibiotics at least for at least 24 hours. And of course it talks about prostatitis here, which we'll go into detail next because that's the next slide. I really like these charts here from your book, your text. So acute bacterial prostatitis. Now that is generally in my years of working in urology, I think I've only diagnosed this once in a patient. Again, these are going to be men who present with pretty much symptoms that sound very much like a UTI, but then they also on top of that have very tender perineal discomfort, and they'll complain that whenever they have a bowel movement, it hurts them rectally, and they'll get referred pain from their perineum, which is the space between your rectum and scrotum, of a man, and they feel pain in their perineum, and it gets referred into the tip of their penis, and it's very sharp and very sudden, and sitting down on like a hard surface tends to be very uncomfortable for these guys. So this is where you kind of think of acute bacterial prostatitis, and its usually onset is quickly. It's not like this kind of insidious, gradual onset of symptoms. It's very abrupt, very sudden, and they are sick. They will have a fever. And so, like I said, in my years of diagnosing this, I've only had to have one come back positive and treat this. And the big thing here is they need to be admitted, because more usually if they do not get that IV antibiotic in them, they will this will turn into sepsis. And again, prostate is it's a very hard gland to penetrate from an antimicrobial standpoint. So the IV antibiotic is initiated, but then they're on antibiotics for quite some time, almost 4 to 6 weeks, at least on Bactrim or Cipro. I've seen longer. My one particular patient was on it for actually 10 weeks. So just this is something that's urgent and quick, but I would say rare, very, very rare. So just to know that, just to kind of look out for that, and from a primary care setting. Now, this is more typical from a primary and also from a urological general urology standpoint, is to diagnose men with chronic bacterial prostatitis. So I wrote here that you need to have a positive uroculture for this diagnosis. Generally, you don't. You can get one. I would say that you can try to culture these men. Um, in the previous slide, the digital rectal exam is actually contraindicated in those patients. They're very sick. Doing a digital in those patients are actually very harmful. You can actually cause sepsis to happen should mess around with their prostate in that sense. But in men with chronic bacterial prostatitis, you can technically attempt to do a DRE. These are patients with the classic board question, the boggy prostate, tender prostate. But these are patients that have everything that what an acute bacterial prostatitis would complain of, but there's no fever. So generally, these are patients that will respond nice to antibiotic therapy. So if you want to avoid the digital rectal exam, by all means, go ahead. I mean, in my treatment of chronic prostatitis as a urologist, will not do a rectal exam on them. They're already in a lot of discomfort, and me probing does not help. So if they have the classic symptoms that are there, I will treat with the antibiotics, and they will report an improvement in their symptoms within 1 week of the antibiotics. So they'll know that there's an end to this if it's truly a bacterial process. So just know that Cipro and Levaquin is the drug of choice, or you can do doxy or azithromycin or clarithromycin as your second line of choice. In our community here, specifically at Penn, there is a known resistance to Cipro and Levaquin, so from a GU standpoint, so we have been treating it with either doxy. That's usually my drug of choice here is doxy. Just know that the prognosis for these chronic guys is that it's chronic, so they can become recurrent, very difficult to cure. Usually, some guys will report that they have these symptoms, 2-3 times out of a year. Other guys will say it's once every couple of years they'll get this, and some guys know that there's some things that they'll do that triggers it, and then other guys they'll say that they know that there's uh, um, no rhyme or reason as far as why they get it. There are clinical trials that are available. I'm so very sorry there. I spelled clinical wrong, but it's clinicaltrials.gov. It has all of the available studies that are out there, and it tells you where they're being done at, or where the PI or the principal investigator is recruiting patients. So you'll find there are lots of clinical trials here in Philadelphia alone amongst the hospital health system here. But just know that I believe there is one clinical trial that's available for guys who have chronic prostatitis. I'm not sure where they're recruiting from, but yeah, just something to consider if you have patients they just want to find some kind of solution. So we'll sometimes consider sending them to these clinical trials too. So again, I apologize for not spelling that correctly. I do apologize that. Next is your non-bacterial chronic prostatitis. So these are your guys with all those other symptoms, but minus a positive culture again. So here, these are pretty much more of an inflammatory response. So these are patients that's going to have those irritating prostate symptoms that you see with the acute prostatitis. There is this kind of, from a prostate clinic, there's a link there. I hope you guys check it out. But basically, this quantifies their symptom so that it will show that their prostatitis has a chronic status to it, and it's a non-bacterial, meaning these are guys who have like 4 or 5 months out of the year will have chronic prostatitis, will have prostatitis symptoms. Usually it's vague. They'll report that they're aware that there's something there, something between their legs. They'll note that they feel it after a bike ride or after some type of a seated activity like riding a motorcycle or their lawnmower. They'll know that triggers it, and it'll flare up for a few days. And they'll take like an anti-inflammatory, and then it goes away. So these are those guys. These are these guys who have these very mild, vague symptoms. And again, when they come to you from a family care setting or a primary care setting, you definitely want to consider just getting the typical basic urine workup, which is the urine microcytology, and of course your imaging, and refer to your urologist if you're really uncomfortable with these patients. Generally, they're coming to see us already. These are patients that may consider, we'll send them to physical therapy, especially if they have any referred pain into their groin, scrotum or testes, or scrotum or penis, and they may benefit from some type of pelvic floor therapy, and so that does help with them too. So just send them over to urology, and that's what we that's what we would do, we would manage that. A lot of times they do respond nicely to BPH medication. So, a lot of their symptoms can be spurred on by, peeing too often and having to wake up 4 or 5 times at night, and that tends to aggravate their prostate. And so then it leads to maybe we can manage them with the BPH medication. So that's your benign prostatic hyperplasia in large prostate patients. Okay. Here is another one. Acute epididymitis is another type of GU infection. These are usually caused by mostly STDs, specifically chlamydia and gonorrhea. In young men, it's usually seen. I have seen my fair share of older men with these issues. Basically, they'll complain of some type of fever, very irritative voiding symptoms, and a very tender scrotal exam. And to you, you may feel an enlarged epididymis. And sometimes actually they may complain of a urethral discharge, and that should be kind of a ding 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 alarm for an STD. Now, you can culture the urethral discharge if you're able to get it. If there's no urethral discharge, it's fine. You can get a urine sample. They can actually do urine testing now for chlamydia and gonorrhea. But just know that chlamydia is typically the common cause. You can get an ultrasound too of the scrotum, as a lot of patients do tend to panic and they worry about, testicular cancer, any type of mass in their scrotum or pain in their scrotum. So just get that scrotal ultrasound just to kind of ensure that it's not, and relieve a lot of their anxiety and it's not a mass. And a lot of times they'll indicate epididymitis on the ultrasound. So just know that you want to treat the actual STD. So you can definitely repeat the ultrasound after you finish therapy, just to make sure that there is no residual disease, which I've done in the past for more so for patient reassurance that it's completely gone. So treatment for this is you got to treat the STD. So in my case, urinary stone disease. So this is something that again, I work it up, but then I end up referring to our attendings to surgically manage. So they come to me presenting with either flank pain or ER discharge. They were in a lot of pain. They went to the ER and they come now to follow up with urology because it's confirmed that they have a lot of kidney stones in their kidney. Now, in your book, it says the stone formation is dependent of solute concentration, ionic strength, pH, and complexation. I will be honest with you, I had to Google that word. And just in case you didn't know, this is what the definition came up as. It's the process of making an atom or compound form a complex with another. So that sounds like such a bored question, but just know in reality, basically you need to have the right scenario for stone formation. So of course you have your 5 type of stones in the order of most prevalent to least. So your calcium oxalate is one, calcium phosphate is the other one, and they're both pretty much equal as far as composition prevalence, and they make up about 85% of stones that are tested or analyzed. Your third type of stone is your Stuvite stone, which is predominantly made up of magnesium, ammonium phosphates percentage or combination. And then, of course, your fourth stone is your uric acid, and then your cysteine stone. So uric acid stones and cysteine stones are radiolucent unless they have some type of calcium combination in there. Then it may show up on a KUB, a kidney ureter. Basically an abdominal x-ray. But just know that most of the time, if it's purely uric acid or purely cysteine stones, they're going to be radiolucent. So you will not see them on a KUB. You may see them on a renal ultrasound if they're big enough and if they're causing an obstruction. But just a kind of little tidbit about uric acid stones. So if they have any history of gout and their urine is very, 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 very acidic, on your test, then consider this as a possible stone in the background, and maybe avoid and go right to that CT non-contrast scan if you really, 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 really think it's a uric acid stone. Now, here's the thing. These patients will complain of flank pain, nausea, vomiting. And usually it's confirmed on a non-contrast CT. They're already presenting at the ER. It's the most intense pain in their life, they usually report, and they're going to the ER for this. So a lot of pain. Sometimes that blood in the urine even prompts them to go to the ER. So these are patients who most likely healthy and their first stone experience, and they usually go to the ER for it. So this is the typical stone movement pattern. If the stone is in the kidney and there's already hydronephrosis, which is an obstruction into the kidney, in the kidney itself, they'll complain of flank pain, and definitely blood will be most likely present. If the stone travels and it actually is in the ureter from from the kidney all the way down to the bladder, anywhere along that track, usually the pain is still in the flank and then it transitions to the groin. So these patients will say that they don't feel the back pain anymore, but all of a sudden they start to feel some like groin discomfort, and it's very vague, but it's not like muscular in nature, and they have a really hard time describing it, but they indicate that it's groin pain. And then there's also blood in the urine that's maybe present. Again, if the stone is moving and it gets to the ureterovesicular junction, this is your UV junction, the junction of the ureter that meets the bladder, and generally the stones here, if they're quite large, can get stuck. These patients will complain of urgency, frequency, the bladder discomfort, and blood in the urine will be present. And sometimes if it causes backup into the ureter and there's no and urine can't get around that junction there, then you can see hydro on a scan too. Hydronephrosis. Now, if the stone is already passed and it's in the bladder, generally the patients will complain of no pain. They'll feel like instant resolution of their symptoms and think that the stone is passed. But sometimes they don't know that. They may have passed it and they may not have passed it. But usually the patients will report that the symptoms have all but dissipated, but they'll still complain of maybe blood in the urine that's still persistent, and that's when they'll come to see us and investigate, and long and behold, we'll get the scans and there's the stone, it's still in the bladder. So just know that if the stone is in the urethra, these patients will know that they passed it because they'll feel it. They feel like a burning sensation. They feel it moving through them, and then sometimes they'll actually note that they hear something hit the bowl, like a clink sound, and so they'll see it or they'll hear it, and then they'll look and they'll actually see the sediment in the toilet, and they will fish it out, and then they get it to me and we analyze it, so we will see it. So just to know some imaging, just know that a non-contrast CT is typically the image of choice, but really if it's renal ultrasound and KUB is ideal if the patient is young or if you're trying to avoid costs. But if they're pregnant, you have to really consider renal ultrasound and refer to urology and OB. Refer to nephrology for any metabolic evaluation. So if there's persistent stone production or lots of stone on imaging, they need to get worked up for cause of it with a nephrologist. They're referred to urology if the stone is obstructed, so we kind of manage them surgically if needed. And of course, refer to the ER urgently if any fever is present in light of having a kidney stone symptom, like these symptoms of a flank pain and fever. So again, go to the ER. Sometimes these patients are considered hot stones, which is basically our nickname for these patients, and they're on our surgical schedule for the day over the next day for stone procedure. Let's see here. So here is the treatment that you're tailored to. It's all tailored to the type of stone and frequency. Remember, if a stone's available, please send it out for analysis. Just know that if it's usually once and done, but about 50% of these patients will experience another kidney stone recurrence again if they don't have any, if they do nothing at all to change their lifestyle. Big lifestyle modifications is to drink lots of water. You need to eliminate at least 2.5 liters a day. It's currently recommended that we drink at least 0.5 to 1 per ounce of basically you want to drink at least half to 1 ounce of per pound of your body weight. Sorry, that was so confusing. So for example, if you're 150 pounds, you want to drink at least 75 to 150 ounces of water in a day. That's a lot of water. But that is the recommended intake. Of course, you can tell these patients to avoid calcium supplements. Now, these are supplements that are like in your multivitamins, that's additional on top of that. So it is okay to continue dietary calcium, like in your milk, dairy product, anything like that. That's any dietary calcium or calcium that's already in diet. Okay to keep and continue. It's just your supplements that they're overindulging on. You tell them to stop. Remember reducing sodium intake because of the concentrated urine. And of course, reducing any animal protein consumption because that leads to stone production also. Remember that the patients with persistent stones need a metabolic workup, and they need to be sent to nephrologists. And again, symptomatic stones are managed by urology. So that'll be us. So in urology, just know that there are non-invasive management that includes a sound wave lithotripsy, and then of course a surgical management, which includes a ureteroscopy and a lithotripsy, or an extraction, sorry, or a percutaneous nephrolithotomy, which is a PCNL procedure. So this is from Boston Scientifica called mykidneystone.com. Actually, our kidney stone specialist at Penn tends to refer to these sites for his patients in regards to patient education and having them understand these two procedures and why he uses one versus the other in their whatever setting that they're in. So on the left is your U-scope. That's your ureteroscopy. So as you can see, it goes into the actual, the urethra, and they kind of basically thread this camera with a type of instrument at the end, and one is it passes this kind of entryway allows them to pass this instrument where they can break up the stone and then retrieve it and remove it, break it up, and then they usually will then pass a basket or a wire or some type of kind of collection tool or instrument and kind of pull it out with the camera and that scope. So that's called a U-scope or ureteroscopy. Now the next one is ureteroscopy. Yes, sorry. PCNL is the other one here on the right here, and this is where it's the access is directly through the back into the kidney and into the actual renal calyxes where a lot of the stone is formed. So these are more so for those where that you find lots and lots of stones in the kidneys that's going to be very hard for them to pass, or a stone that's very large that's going to be very difficult to pass. So those are going to be your 10 centimeter, or sorry, 10 10 mm kidney stones. So very big stones, almost a centimeter stone size center stones are not going to be able to pass. Just a kind of a general rule of thumb, anything that's bigger than 5 millimeters is going to be very hard to pass through the ureter. Anything less than 5 millimeters can be passed through the ureter. And the size of the stone has no correlation to the severity of the pain. And that is the truth about the kidney stones. This is just kind of a picture graph of all the stone. I wanted you to be familiar with this. So calcium stones, a lot of people think it's going to look white. Really, it actually is brown and black when it comes out. So just know that this is what it looks like. This is what I think. This is what I tend to see with calcium stones. Struvite stones, they look like this. These are very jagged looking, very painful. Looks like very painful as it comes out, but they can get quite large. This is your uric acid stones. It looks like crystals. This is your cystine stone. Again, this also looks like crystals too. Both of these, remember, are radiolucent. And these two other stones are very extremely rare, and I tend to not see these actually. I actually have not seen any of these actually. Okay, so penile dysfunction. So another ballpark in urology here, or another field here. So erectile dysfunction, I would say, is pretty much predominantly 95% of my practice, and the reason why is because of my patient population. I deal with men post prostatectomy, and so their biggest complaint is going to be incontinence and erectile dysfunction. So those are kind of the two kind of subject matter that I talk to a lot about our men. So just know this progresses with age. A sudden onset of this tends to be from surgery. So it's going to be those radical prostatectomy patients from prostate cancer. And so those are the patients that will complain of ED quite often. So the definition of an erectile, or a definition of this, is inability to attain and or maintain an erection for penile penetration for sexual intercourse. And so that's the definition of that. Now just understand the pathophysiology of this. I'm not going to go into too much detail of this, but just know that a normal male erection is a neurovascular event. So you need neural stimulus and neural integrity with vascular response and integrity. So just know that it's a combination of the two that's going to lead to a healthy erection. So just know that the big takeaway on this picture here, or this chart here, is the nitric oxide. I believe this is something that is very board related, I guess you can say, is this neurotransmitter that's a big key factor in erectile dysfunction is nitric oxide. And as we all know, if you kind of learn in pathophysiology or endothelial physiology, where nitric oxide comes out of, your body makes this, and especially in your vascular tissue, nitric oxide is a component of, or a result of that, of a healthy vascular function, and it aids in blood flow. So if you have more nitric oxide, you have very good healthy blood flow. If you have poor or low availability of nitric oxide, then you have very low blood flow, okay, or blood perfusion. So in men with this, the cause of this, or how this happens in men, is as they get older, there is decreased arterial flow, so blood flow, because of progressive vascular disease. So it goes hand in hand. So if you have poor vascular disease or progressive vascular disease, you're going to decrease that availability of nitric oxide. And so these are men who will report that they have some issues, with achieving and maintaining their erection. Usually they'll report maintaining is the first to go, and then eventually kind of the achieving part kind of catches up. So remember, just consider that, know that there's lots of causes to this, and you have to consider all of your options. But if you understand the pathophysiology of this, really understand it, then you'll be better off explaining to your patients why they need to change their lifestyle. I think that usually is my number one conversation I have with my patients when they come in to talk to me about ED is, they'll complain that they have issues maintaining their erection, but then I look at their kind of health list, and the number one is on there is diabetes, and then they have also hypertension, and also they're obese. So talking about the three there, top three, and getting them to get off their blood pressure medication, get their diabetes under control, and also losing weight, they will report probably about a 25 to 30% improvement in their erection just alone. And that's just my personal data of being in clinic, so that's not a board thing, but that's just something to consider. So just know that if they're just the kind of the workup for this is basically if they're really complaining of erectile dysfunction on top of loss of libido, then you definitely have to refer for an endocrinologist to kind of work them up for low testosterone and make sure there isn't any underlying causes for low testosterone. Imaging is typically not required for ED, okay? Just the treatment for this is, again, like I said, lifestyle modifications and changes. Usually the culprit is the result of vascular disease, so can we at least prevent that or somewhat slightly reverse the cause of this, so reduce that plaque formation? So smoking is a big one, heart healthy diet. I usually encourage guys to increase their cardio, exercise, get their diabetes under control, their cholesterol under control, and let's see if we can get them off the hypertension medication, or at least reduce the number. There's also a psychogenic component, which is probably maybe I wouldn't say a big portion, but it's contributing portion, because they feel it's more of like a very cyclical process for these guys. They kind of feel already emasculated, and they're gonna feel less desire to prove themselves, so they kind of spiral down this hole of not being able to perform. So break that cycle. You can reassure them, become their champion, become their cheerleader, and any little improvement that they see is always a bonus, and you can cheer them on for that. So I do encourage my guys to really embrace any improvement that they see in their erection. Medications to consider, like I said, if you can get them to change their lifestyle and maybe help them a little bit along the way with medication, do so. I hate to see, a lot of doctors kind of throw the medications at them and say, here, try this and good luck. But no, you got to really talk to them and really encourage them. So anyway, the medications are sildenafil, which is your generic Viagra, vardenafil, which is your generic Levitra, tadalafil, which is going to be your generic Cialis, and avanafil, which is the generic version of Stendra, but it is not available in our pharmacies yet. Remember, these medications have no impact on the libido, and priapism, which is a prolonged erection, is extremely rare with these medications. So I know we've seen in the movies how they take the medication and they have a prolonged erection. It's actually extremely rare with this medication, with the oral meds. But remember, if they are on this medication and they experience any type of chest pain, they cannot take nitroglycerin. So it is contraindicated in these patients. So for my guys, there are some guys who were prescribed nitroglycerin for a MI episode they had 7 years ago, but they hold on to this kind of this vial of nitroglycerin, and they'll tell me, I've never used it. I haven't used it in 7 years, but I carry this vial. And so they'll come and they want to talk about using Viagra or Cialis, and I'll give it to them under the stipulation and strong advisement that should they develop any chest pain while they're on this medication, they cannot reach for the nitroglycerin. They have to take their aspirin and go to the ER. But they know, they are educated thoroughly about the contraindication of taking nitroglycerin with Viagra. Just know that the combination causes the blood pressure to drop or bottom out, and they are coding in front of you. So just be aware of that. And okay, and also this class of medication can be okay to take as a combination with a alpha blocker. Okay, like a Flomax. All right. Now, another option for erectile dysfunction are injectables. This is a personal favorite of mine for a lot of my men who are post, again, radical prostatectomy, and so these are patients who fail on oral medication and a kind of and they're just not keen on using like a vacuum erection device, which is this external pump, which is on the next slide. So this is what it looks like. I tried to use the least graphic picture possible to show you this, but basically it's an injection that the patients do draw up. We prescribe it, they draw it up, and they will self-inject the medication. And usually, if you are looking down at yourself and the penis, it's at either a 1 o'clock or 11 o'clock position that they're injecting. And the medication, the main ingredient is a prostaglandin, which is uh, uh, the main ingredient of these medications that basically increases vascularity and increases blood flow into the corpus cavernosum, which makes it erect. So I used to tell patients, or at least try to describe this medication. This is something that was very popular before Viagra came out. And so pre-Viagra, this used to be the drug of choice, the compound of choice. And then after Viagra, when, of course, the option to take an oral medication over an injection was by far favorable, this became a little bit more on the backside, but it is still our go-to drug for our men who do not like the oral medication because of the side effects, or they failed on the oral medication. Okay. Next slide here is about the vacuum erection device, another treatment option for erectile dysfunction. Again, this is something I encourage our guys to use. This device is technically safe. The patient can control the outcome. We tend to order this from a medical supply company because it's reliable. They have a warranty to it, and the plastic on it that creates its seal for the suction to work. It's very durable. I have had men who have bought pumps either on Amazon, and it's cheaper. It's like $25-$50 cheap. But usually after multiple uses, the plastic tends to crack. So with the medical device and also the devices that you buy from a lot of the adult stores, reputable adult stores, I should say, are actually very good material. They're slightly more expensive for that reason, but it does work. So yeah, I've become familiar of a lot of the adult stores in this area, Philadelphia, and of course your suburbia county. So again, I recommend this to guys. I like it personally for our guys to use it for physical therapy and also for sexual intercourse. So from a physical therapy perspective, they're pumping this up, exercising their penis, getting just that blood flow into their penis to feel that sensation. And then of course they'll use it for actual intercourse where they pump it up. And you can see in the one picture there are these constriction rings that you kind of set up on the pump so that when they pump their penis to a size that they feel comfortable with, they'll roll the ring down and trap the penis or blood in their penis. And so then they have this stiff, rigid erection that they can use for penetration. And so the device down here is the most common device I prescribe, which is the manual device. It's a manual vacuum erection device from Osbon. Okay. Of course, the last resort here is your surgery. You have your penile prosthetic surgery. Of course, you're going to be referring to urology to talk about this, but basically you have lots and lots of devices out there. The main components are there's going to be a reservoir, which is usually seated or inserted really high in the belly, kind of closer to the bladder, and that reservoir is usually filled with saline water. And then, of course, you have your instrument itself into the penis, that kind of the cylinder that makes the penis erect, and then the pump, the on-off button, as you say, is usually in the scrotum. And so a lot of the guys, what they do is they'll push the button in their scrotum, and it releases the valve to allow the saline solution or water enter into the cylinder and get it erect, and then it kind of holds it there. And then when they're done with their activity, they will hit that button again, their pump again, and it deactivates it, and then the fluid kind of retreats back into the reservoir and back into that system again. So just something to consider. So, Peyronie disease is another type of penile dysfunction. Basically, this is a fibrotic disorder of the tunica albu. Sorry, I cannot pronounce that, but it's the basically the sheath around the cavernous the corpus cavernosum. So basically, it's a sheath that's around there. And what happens is there is usually some type of either trauma or degradation in that sheath, and it causes a formation of a plaque, a fibrotic plaque formation, and it causes it to pull the penis in that direction. And so you see this with trauma or with men who attempt to penetrate or have sex with a semi-hard penis, and it causes kind of these micro trauma to that spot, and it causes it to bend over time. And so this is a very, I would say, pretty prevalent. I would say 25 to 30% of our men will show this, but just know that on the boards, this is tend to be associated with Dupuytren's contracture. So just know that that is something that usually, if you see a history of Dupuytren and they talk about anything urology, this is what they're referring to as Peyronie's. Okay. Now, another penile dysfunction is priapism. Again, this is prolonged erection for more than 4 hours. I did not want to post a picture up of what I found online. I wish I had some from our hospital, but the ones online usually shows a strangulation as a result of, or priapism as a result from penile strangulation. So those pictures tend to be quite graphic. But just know that the most common cause for spontaneous priapism in our patients are generally patients who have sickle cell disease that's poorly managed, or if they did do some things, for instance, tie or basically insert their penis into something that's quite restrictive and we're unable to get it off. So that's a common one. The goal is to hopefully not allow tissue degradation or breakdown. Basically, we just don't want to have a dead appendage. So yeah, we have to relieve that pressure immediately. The skin will be blue. In my either Caucasian and African American patient, you can see the skin. It is blue. It is purple blue. This is a urological emergency, and they need to be referred to the ER. So it's another type of penile dysfunction. It's some ejaculatory dysfunctions here. Most of the PCPs tend to refer to us when patients do complain of any type of ejaculatory dysfunction. So the three common here is your anejaculation, so there's no ejaculate, retrograde ejaculation, which is they do report that they see an ejaculation, they do see seminal fluid, but then it's half of the volume that they're used to seeing, and then when they pee, they see it come out of their urine, and they just want to know why. And then the other one is premature ejaculation. So usually no ejaculation, a big result from radiation treatment or surgery treatment for prostate cancer, or if the patient has an androgen deficiency either through congenital or acquired. And so that usually is two extremes, cancer versus congenital malformation. Retrograde ejaculation is a very common side effect of medication, specifically alpha blockers. But another one is sometimes we see this in patients who've had any type of prostate procedure, not a radical prostatectomy, but like what they call a resection of the prostate to reduce the size of the prostate. Then we'll see men report this kind of problem where they see either very little to sometimes no ejaculatory fluid when they climax, but then when they urinate, they will see it come out through in their urine. They'll see cloudy urine. This will definitely happen in guys with alpha blockers, so let them know this, warn them about this. I've had a lot of guys who come to see us after seeing their family doctor being started on like Flomax or the generic is tamsulosin, and they're so upset because now they have no ejaculation, and that's why they're seeing us. It's because they don't see any more ejaculate. They're still taking the Flomax, but they're so upset. So it's just something to really keep in mind about that. Premature ejaculation, again, this is more, definition is basically they are ejaculating before they desire to ejaculate. So it could be within seconds to minutes after any type of stimulus. A lot of times we have to address the behavioral issue and the psychological underlying issue. And so a lot of these patients, we will refer to a behavioral sexual therapist. we will treat them and help them at least to maintain some type of control with a topical anesthetic agent. Promescent is a very popular one that's available over the counter. It's a type of a topical lidocaine spray or numbing spray, and it does help kind of reduce that sensation so they can last a little longer for more for intercourse. So, but yeah. So, male infertility. Now, this is something that is a subspecialty. Just know that the feature physical exams are going to be geared towards just looking for any type of features of your hypogonadism, such as like underdeveloped secondary sexual characteristics in men. Their body habit is like, do they have is it obese? Do they have breast tissue, and also is their testicle slightly smaller than normal, or smaller than normal, or absent even, and if they have varicoceles on their scrotal exam. So those are things that we look for. The more documentation you can get, the more likely you can get at least coverage for them from an insurance perspective as far as the workup that they're going to require, especially like blood testing and genetic testing. So the more detailed your physical exam is geared towards any type of abnormal finding, it's better for the patient and in regards to getting their fertility workup covered, and a lot of the fertility treatment covered too because of it. So a varicocele, which is on your pants blueprint, but not so much in your book. It doesn't actually, there wasn't much in your book at all about this. Just know that the varicocele is usually an abnormally dilated veins of the plexus here in the scrotum. When you feel it, or when you palpate it, it actually feels like the word that they use here is bag of worms. At least that's what they used in my old study guides, but it feels some slightly like more pronounced vessels. So usually one side is more pronounced than the other, and you can tell the difference. So just know that's what a varicocele is, and just more so for physical exam purposes. Now remember, the semen analysis, there needs to be at least 2, and they must at least be 3 to 5 days apart with a ejaculatory abstinence. So they cannot have sex or masturbate in between that time frame. And they have to submit a live specimen, so they usually come to a specific lab that does semen analysis, and we do the analysis usually within 1 hour of the collection. And generally, these are the 2 kind of most common diagnoses that comes out of men with an infertility issue, is oligozoospermia, sorry, that should be a ZOO, which is a low sperm count total, and then azoospermia, which is no sperm in their semen analysis. So generally, the urologist is going to talk to them about that, the fertility specialist. The blood work that I ordered up for my doctor is, again, here listed. You're going to do your hormone panel, and I do an STI panel just to make sure that's not impeding on the workup or the production of sperm. Just know genetic testing is also something we order too. That's something that usually once he consults, or the patient consults with the fertility specialist, these are the type of testing that can be done through blood work. So karyotyping, Y chromosomal microdeletions, and CF are screened on all 3. It's very costly, especially if there is no physical exam to back this up, but generally most of these guys will present with some type of secondary characteristic issues. Imaging is, you can get a scrotal ultrasound again to see if there's any vas deferens abnormality, or if there is a testicular mass or a varicocele. Okay. So the treatment really depends on the workup and what it reveals. So the blood work and the karyotyping and the genomic testing, many will be on some type of a supplemental endocrine therapy to boost their own sperm production. Some may require some surgical intervention, such as a varicocelectomy or a vasectomy, reversal. For some reason that autocorrected to referral, but a vasectomy, reversal, and sperm extraction. I'll probably correct it before I send it to you guys, though. But some will require assisted reproductive techniques, such as an IUI or IVF. So that is something that is a very hard discussion, but a discussion we have with all of our men and the female patients on the female fertility side. Let's see here. Next topic is benign prostatic hyperplasia. So this is your BPH, your enlarged prostate. And again, I would say this is a good chunk of my guys too. On top of the ED. So these are benign tumors of the prostate, and it is usually a result of enlarging prostate over time. Remember, a normal sized prostate is generally between 25 to 30 either grams or cc's or mLs, depending on which scan you order. They usually pick one of those for volume definition, I guess. Well, a lot of times these guys usually complain symptoms of as early as 40 years old. The enlarging process usually starts around that time too. And usually by the time they're 80 plus years old, about 90% of these guys will have BPH. So this is something that grows with age. It comes or grows with time. The symptoms usually become more bothersome, and by about usually guys will come see the urologist usually in their 50s because the symptoms have now progressed. If the symptoms present before the age of 60, it tends to run in the family. So usually they'll say, my dad had this problem too. He always had to go to the bathroom all the time. And so usually you'll hear that in their history. They'll say they knew like their father or their uncle or their grandfather had this. Now, signs and symptoms of guys with BPH are going to be obstructive symptoms and irritative symptoms, generally just like the prostatitis, but remember, none of the fever and none of the pain either, no pain. So just know that a digital rectal exam will reveal an enlarged prostate. And this AUA index here chart, which is actually from your text, we use this in our clinic. All of our new patient, male men and female patients, answer this question in regards to their urinary symptoms. So we find that this is actually very helpful in determining, their type of incontinence and how bothersome is their symptom that should we intervene. Okay. So we use this in all of our questionnaire surveys. So if something you can adapt in your clinic, then it's very good. Here is your benign prostatic hyperplasia workup lab. So you definitely want to do your typical urine studies through all infection and make sure there's no microhematuria on exam. A PSA is something that I ordered too on these guys just because now they're on our kind of workup. Again, we talked to them about the usefulness of PSA screening in men with BPH and of course the screening for prostate cancer. Imaging is generally not required for these guys unless they have really severe obstructive symptoms, and we'll get the imaging for it. But generally, this kind of flow chart here does a very good job as far as what you need to do as far as should you do some kind of workup or imaging. Okay, so I like this flow chart, very nice to follow. So it's just the treatment protocol is usually a monitor the symptoms. So some of these guys just want a little reassurance that this is normal, what they're going through is normal, and that they don't have prostate cancer. And so really a lot of it is patient education and making them aware of the role of a PSA and their symptoms for BPH. So they're going to just want to be monitored. There are guys who definitely want to do something about it. It bothers them too much. They just want to feel like they can sleep through the night. Those are the complaints that they want fixed. So you can use medication management for this. It's going to be your alpha blockers. See the chart here. Generally, the first drug of choice is going to be tamsulosin, which is all the way at the bottom there, not tadalafil, but just above that. That's your Flomax, your generic for Flomax, and that's the most common first-line drug that we tend to use. It's trial and error. You can go through this. A lot of people have their personal favorites, what they see in clinic. For me, I tend to start with Flomax first. It's the most common one, and then it's hit or miss. The guys say that they don't feel much at all with that, then I'll go to the next alpha blocker to see if that works. So it's trial and error with these guys. Okay. Now, if they already have a ED component and they also have BPH symptoms, you can put them on a combo therapy, which is the generic Cialis, the tadalafil, and it is FDA approved to treat for both BPH and ED. So insurances are becoming a little bit more favorable with that, but it's still they still want the patients, the guys, to try an alpha blocker before jumping right to the Cialis or tadalafil. Now, some combination therapy you can consider, which is an alpha blocker with finasteride. You can definitely do that. Now, finasteride is used to, it's not mentioned in your book, but finasteride is technically the thought or the mechanism behind it is that it shrinks the prostate over time. Not dramatically, it does take time, but it inhibits the activity of the prostate itself, and so technically you kind of either slow down its growth and sometimes reverse it. Not 100%, but you can slow it down. Just know this is a clinical pearl, meaning it's not in the book, but it's something you need to know as a clinician and in practice when you prescribe this. is that finasteride will mask the PSA numbers, and it's usually they'll mask it by having the results in the lab test. So for example, if the person's PSA is 3 and they start out on finasteride, then the PSA will be 1.5 in their lab should you repeat it again. Now, should a PSA ever rise on a finasteride or on the finasteride, you need to refer them to urology, because if this medication is supposed to reduce or to create inactivity within the prostate, then your PSA should be really low and respond to that. But for persistent rising PSA on finasteride, there's an underlying process that needs to be investigated. And if you're sitting there and you're ready to come to that conclusion, it's the big C, it's cancer. So it's something we need to work up. Now, surgical intervention is required, or if it's required, then refer to urology for this consult. So a lot of the surgical intervention is usually when patients fail medical therapy, or if on imaging their prostate is very large, it's measured to be 80 cc's, grams, or mLs over, and then they have this chronic urinary retention too on top of it, meaning they're now using or have to use an indwelling Foley catheter, or they're intermittent, or they're self-catheterizing themselves, so CIC. So the surgical interventions involved, which is a TURP, a TUIP, TULP, HOLEP, or TUNA, which are basically all of that are types of transurethral approach of treating the enlarged prostate. A simple prostatectomy is a surgical procedure where they are put under. The approach is to go through the belly and get to that prostate, quart from the inside out, but leave the prostate intact. So very different from a radical prostatectomy, which is the complete removal. Something a little bit non-invasive is Urolift, so this is becoming a little bit more popular. Resume, I've gotten a lot more patients asking about this. We do not do this at Penn yet. And hyperthermia treatment are options. I do not believe hyperthermia is something we do at Penn either. So the other transurethral approach that you see there and the simple prostatectomy, Urolift, are all available at Penn, or common at academic, I believe. Okay, so prostate cancer. So we're going to head on to GU cancers here. So prostate cancer. I would say this is the most common cancer in men and the second leading cause of cancer-related death in men. I could spend, hours lecturing on prostate cancer, the surgery itself, the radiation through treatment, and the side effect protocol. But just for a class purposes, and also for just for your own personal primary care purpose, like if you're going to be a PCP out there, just know that this is something that has been severely controversial in the last 10 years because of the guidelines that came out from the USPF task force. So it is still an ongoing issue, and so just please read and ask a urologist, ask a GU or an oncological urologist about it. So some risk factors to consider: African American race will increase your risk. The risk factor for prostate cancer, family history of prostate cancer will increase it, and any history of a high fat intake. So that's like your red meat diet that you hear about. Now, generally, on a DRE exam, you may feel a nodule on the exam. So I always tell our people who want to know what a prostate feels like, if you actually just touch or feel the inside palm of where your thumb is, that inside palm where your thumb is what a normal prostate generally would feel like. So slightly firm, but yet still, mobile. So that's what it should feel like. Should it feel harder than that, or if you feel an actual nodule in that, then you should prompt an investigation, send them to urology. Most of these DRE exams are benign. So in my years of urology, of all the prostates I felt, I would say I've, maybe about 15% of the guys I felt something. But most of these guys, when I send them for any type of workup, it's because of their PSA. So again, the serum, the PSA blood work is the most common testing that will prompt a urological investigation. Okay, so some of these guys will just come in and see a urologist for thinking it's BPH symptom, and then we'll get their PSA checked, and then it kind of veers them down this pathway of now they're getting screened for prostate cancer, and then they have to be worked up for it now because of it, because either the PSA is high or abnormally high for their age. So just know that having BPH does not increase the incidence of prostate cancer and vice versa. So they are independent from each other, and I usually reassure the guys about that in regards to their BPH symptoms, okay? Let's see here. Now, lab tests, of course, your PSA. Your book indicates that a PSA greater than 4.0 nanograms is elevated and prompts urology consult. However, for us, if there is a greater than 1 nanogram of change between two PSA without any underlying cause, such as prostatitis, bladder infection, and there's a family history of prostate cancer, you need to really consider a referral to urology. So this is an example. If it's someone who has a PSA of 2.0 and then all of a sudden increases to 3 and remains at 3 or higher upon repeating it, and these are patients that really need to come see urology. Some other blood testing is a PHI, which is a prostate health index test, and a 4K score. These are not standard of care testing, but they are available in urology. It's more information to prompt a patient to have a biopsy, but it does not replace not having a biopsy. So if they have a history of elevated PSA and the PHI test or a 4K score test is ordered and they still come back high, they still need to have a biopsy. Okay. So this kind of nomogram here, also coming from your textbook, is actually very similar to how we practice in urology, at least with my attending here, who's very strict with PSA and age. So this is a very, very, very good flow chart for screening PSAs and how to follow that route from even um, a primary care setting. I think this is a very good guideline, and it came from the NCCN guideline, which we like very much so. I think they're even stricter than AUA guidelines, to be honest. But so just know that a urologist will perform the prostate biopsy. We generally do it transrectally. There is a transperitoneal approach. It's becoming a little bit more common, but right now the most common is your transrectal. You can be sedated or awake for this. Usually 12 cores are sampled. Now, if a biopsy is positive for prostate cancer, it is then scored based on the Gleason score from 6 to 10. Your book says 2 to 10, but a pathologist do not score lower than 6. So just know that this model, again, this NCCN model is fantastic, and I think that this is very strict, but but it follows in line with how at least a urologist sees and views a PSA. Okay, now, so just to kind of understand Gleason scoring system, I kind of put this here. You do not need to know this for the boards. It's just more of just to know that this is how we look at it. So your grading scale is on the left. So the grades, Gleason's pattern scale or grade is graded from 1 to 5. And then the score is the combination of one or two of those grades that they see on the specimen. So just know that grades 1 and 2 are generally not used in the scoring the score from a pathologist. The lowest they'll start at is 3, and then they go from 3, 4s, and 5s depending on what they find on their assessment, on their analysis. And then from there, they'll come up with the combination of 6, 7, 8, 9, and 10. So just know that that's usually how a Gleason score comes up, okay? As far as imaging, generally it depends on the Gleason score. An MRI prostate and a bone scan is strongly recommended. In our in urology, or in our guidelines, it recommends it for patients who have a Gleason 7 or higher. It's strongly recommended to get those two imaging. What's available now is a PET scan with an oxygen radio tracer, or fluciclovine is the name of the dye, or the generic name for it. It was recently approved by the NCCN guideline for recurrent prostate cancer. So that's been very nice to have as a scan after they've been treated, and they are now showing PSA recurrence, meaning detectable PSA on blood work. So generally after treatment, there's usually either a non-existent or reduction of their PSA, but should their PSA rise after surgery or radiation, then they're considered recurrence. So here's your treatment options for prostate cancer. Very controversial still is this after surveillance. Then you have your radical prostatectomy, which is primarily what I do. So slightly biased, but it's okay. The other option is also radiation, and of course then there's androgen deprivation therapy or hormone therapy. So these are your top. Basically, after surveillance is a protocol that's used for a lot for guys who just strictly wants to avoid any radiation or surgery, and they're very low risk prostate cancer. So these are guys with Gleason 6 score, 3+3 grades, and they're prediction or projection or prognosis of mortality in 10 years is like less than 1%. And so these are the guys who are going to want to do active surveillance. For radical prostatectomy, just know that there's open versus robotic. The robotic is becoming more common. Remember, the technique is improved, so men can recover from urinary incontinence and ED. But all men will go through a period of incontinence and erectile dysfunction. Again, age of the patient, they're younger and they're healthier, tend to recover much quicker. Local recurrence after surgery can still occur because that's determined independently by the tumor stage and Gleason score. And so just know that if there's T3 disease or biochemical recurrence, we'll refer to radiation. Now, for radiation therapy, this is another alternative. In your book, it actually indicates a local recurrence after radiation with a confirmed biopsy. These patients are at an increased risk of cancer progression and cancer death. You have to consider secondary cancer risk to bladder and rectum, especially from the radiation exposure in about 7 to 10 years. And usually it's not ideal for men under the age of 55. So just something to really consider. So the androgen deprivation therapy is your hormone therapy. And usually this is used in combination or adjuvantly, as they say, with radiation, rarely with surgery. So prognosis, usually after treatment, we follow the PSA indefinitely, both radiation and surgery. So we want the PSA to be undetectable in surgery specifically. In radiation, then usually their PSA will actually decrease significantly and it'll be very low, like usually under 1. If it becomes measurable, meaning a PSA that's greater than 0.2, this is considered a biochemical recurrence of the cancer. There are many nomograms to use to predict the likelihood of recurrence of cancer, and it really is dependent on that final Gleason score and tumor grade. So generally, for T2 and T3 disease, mortality is still less than 2% in 15 years, even in light of a possible cancer recurrence in that time frame. So these are the top 3 nomograms. I personally use the MSKCC prostate nomogram. That's my one. Then I use Capra nomogram too, especially for my patients who are very inclined in data information and data, just they want more information. So I'll pull up the Capra nomogram also. And of course, the last one there is Catan nomogram. So these 3 nomograms, they're wonderful. You just plug in the information from the pathology report and it spits out the number for your recurrence and prognosis, and generally very, very good findings and good numbers for the guys. So it's more reassuring for them. Bladder cancer, this is your second most common urological cancer. It's more common in men than women. Now, the history of smoking is the biggest risk factor. So these patients will complain of blood in the urine and you do the workup, or they'll have no other symptoms besides blood and they are a smoker. You got to first rule out that bladder cancer. And of the bladder cancer cell line, the urothelial cell carcinoma makes up about 90% of the bladder cancer. So just know that signs and symptoms is generally asymptomatic hematuria. Remember, these patients have no other presenting symptoms besides just the blood in the urine, not even a UTI, and you'll get the workup and you'll rule out that UTI and they still have persistent blood. So refer to the urologist when you see this. And remember, you need to have that urine microscopy, positive RBC on the urine micro. And then, of course, if you're really suspicious in them and you kind of go the extra mile and order that urine cytology is excellent for high-grade lesions, but it doesn't rule out low-grade lesions, so you still need to do the workup. So high-grade lesions can be seen on this urine cytology. They're very sensitive for it. Now, imaging for this workup is a CT urogram, a pyelogram. Now, you have to consider an MRI urogram if nephrotoxicity is a concern. And, of course, the procedure is to do a cystoscopy with the biopsy. Okay, sorry about that. Proceed. Now, the treatment for this really is dependent on your biopsy findings. You have medical oncology that plays a big role for very high-grade disease tumors and infiltrative disease. So just know that these are all your treatment options. So intravesical therapy, it's usually managed by urology. It's basically us injecting a chemo agent into their bladder. The most common chemo agent that we use is BCG, and unfortunately there is a shortage for that right now across the nation. So it's quite terrible there. So we've been alternating between BCG and Mitocin. So But yeah, just know that BCG is the common one, and it's a bladder installation. Surgery involves either partial or radical removal of the bladder, and usually a urinary diversion is created for these partial removals with using a small or large bowel to create that kind of conduit. And again, we manage that. We're the surgical management on that. Now, radiation therapy is considered for patients who are poor candidates for the surgery, and usually they're done in conjunction with or competing in conjunction with chemotherapy. And of course, chemotherapy and radiation is managed by radiation oncology, chemotherapy is managed by medical oncology, and of course, immunotherapy, which is new and emerging. It's considered a second-line agent for metastatic bladder cancer, and it's usually managed by medical oncology. Just know that the staging for the bladder cancer really matters. Stage TA and TIS which is in situ prostate, or I'm sorry, in situ bladder cancer, and then of course stage 1 T1, which is into the muscle, but not into the I apologize, I'm blanking on the deep tissue muscle of the bladder. But generally, these patients have a very good prognosis with an 81% survival at 5 years. Now, stage T2 and T3 is about roughly 50 to 75%, or you have a survival at 5 years. Our prognosis. And of course, if there's already metastatic staging, so that's usually your T4 disease or higher, the long-term survival is extremely rare in these patients. So their life expectancy is usually 3 to 5 years for those patients. So yeah, we try to make them as comfortable as possible at that point when we already see metastatic disease on imaging. Your other GU carcinoma is renal cell carcinoma, such as kidney cancer. So this is the number 3, your third on the list here. So usually a lot of renal cell carcinomas are incidental findings. Some are found during a hematuria workup, but I think most are incidental, like I said, on a CAT scan because they came in for abdominal pain or some bowel issue, and we'll find a kidney lesion or cyst. Now, there really isn't any symptoms in these patients, like I said, because most of them are incidental, but hematuria can prompt this investigation, which is where we'll find it on a CT scan. Your book says I think it makes up only about 10% of the diagnosis, but our findings of hematuria. But just know that if you do order a lab or micro, it may present on a urine microscopy, but they probably didn't physically see actual blood in the urine. Now, imaging is definitely most common to identify, and it's found. And if it is found, you refer to urology. So we would typically follow these tumors depending on the location, the size, the person's age, and so on. So we do consider surveillance in some of these patients, especially if they're older, they're in their 70s, and it's in a location that is not problematic and the renal function is fine. And so we'll do serial follow-ups with them. Now, of course, the treatment for this is a partial or a radical nephrectomy, and these are usually ideal candidates for if the other kidney function is normal and it's a solitary tumor. I mean, it's only one tumor, and we call it exophytic, so kind of sitting just on the borders, on the outside of the kidney itself, still encapsulated, but just sitting off of the kidney. So for patients with really significant comorbidities, like who very sick looking or very sick patients, they're going to be more, and especially if their tumor is less than 4 centimeters, we're going to push for surveillance with those guys. Because the surgery for a radical nephrectomy and partial nephrectomy is quite serious. So yeah. Staging for these tumors, T1, T2 are very good tumors, and usually these are tumors that are confined to the capsule of the kidney, and these guys are usually 90 to 100% disease free at 5 years. So that's really good. Our stage 3 kidney cancers, this is if the cancer is already outside the renal capsule. It's a 5-year survival of 50 to 60% in these guys, our patients, male, female. Of course, stage 4 is metastatic and nodal disease, and 5-year survival on these folks here is 0 to 15%. But this is a big reason why radical nephrectomy may be indicated in these patients, especially if the mets is solitary, meaning it's just a single node and we can get to it and remove it. Then we may increase their survival, 5-year survival, to 15 to 30%. So surgical intervention is still something considered in these high-grade tumors or stages. So, testicular cancer, we're almost done, guys, I promise. So, testicular cancer, this is the most common cancer in men aged 20 to 35. This is definitely a board question for sure. They always bring this up because it's something that is, you can feel on exam and you can work this up. So, for a lot of these patients, usually some type of history of a congenital malformation like cryptorchidism, sorry, where the testes did not descend, and a lot of board questions, a lot of favorite board questions is what side is the most common, and it's usually the right side, and has something to do with the embryological development of that right side. And again, if you want to get into a little more detail about it, you can definitely look it up, but just know that that's sometimes right side is the more common side. Now, there are germ cell tumors, and there are two types of germ cells. You have your seminoles and your non-seminoles, and the most common one generally is your seminolar germ cell tumor for testicular cancer. I found this chart online, which is wonderful. It actually breaks down the cancer tumor markers that tend to follow specific germ cell tumors. So, as you can see, very nice to follow here. So, easy enough. I think this is a great cheat sheet, especially if you go working into oncology or any type of oncological surveillance. This is great. Kind of a little cheat sheet here. Just know that testicular cancer, these are guys who are very. Now, the treatment in your book, it offers a lot of surveillance for like the type of cell line it is, but in reality, 99% of these patients are going to be treated, or it will involve an orchiectomy, okay? And usually if they're really young and they're diagnosed with this, we talk to them about sperm preservation consult and if they want to plan for any future fertility. So they have a fertility consult on top of that. And then medical oncology is involved because once we remove that that mass or that testes, and we finally break down what's involved, what is it, seminoa, non-seminoa, and you know, and if their workup on their CT scan shows that there's lymph node involvement, they're getting medical, they're getting chemotherapy. So I don't know. Your book talks about active surveillance in these guys with known masses and suspicion for testicular tumors, and we don't. I've not seen or heard any of my attendings recommend any type of surveillance for testicular masses. So so just an FYI. You can choose to follow this for board purposes or for your testing purposes. You can definitely go by the book, but just know in clinical practice that testes is coming out. So other urological conditions on the PANTS blueprint, but wasn't dedicated as a section in your book. So I just threw this extra in there for you guys. Balanitis is a very it's a condition that I see more so in my patient population who are you know, hygienically, you know, I guess, deficient, I should say. So the most common cause of this is going to be a fungal infection, and usually I tend to culture it. I'll swab it real quick just to make sure there isn't any superimposing like staph infection, and a lot of times it does. It has a very raw looking appearance. So that top right picture is going to be your typical balanitis. This is a really extreme case because now it's you know, extended into the shaft of the penis. But generally, balanitis definition, it starts at the gland, so just kind of at the head of the penis there, and that's what it looks like, a beefy red color. The skin looks like it's breaking down, and it's usually fungal in nature. But if you have the culture ability, culture it, and if you get a staph off of it, treat it with staph, okay? I tend to give them an oral antifungal medication because a lot of these patients, you know, if they can't, they're not going to adhere to a topical agent and apply this every day, especially if they're not going to have access to like a shower or, you know, bath, you know, basically a bath. And so I give them an oral antifungal, which is just like this. It's basically the same treatment I use for yeast infection. So that's what I put them on, and it's a dose spread out in 3 days. So one dose, and in 3 days they repeat the dose again. And then, of course, if their partner has any type of fungal infection, they can pass it back and forth to each other. So generally, you want to treat the partner also so that both parties are treated for this fungal infection, okay? Now, if the infection is really bad, and this is more common with my uncircumcised male, is that their skin actually becomes unretractable. So the bottom right picture is a foreskin that they cannot retract, and it looks very tight, as you can see, very tight and taut, and unable to pull back. This is something I pulled off of Google imaging, but that picture there is what my patients will present with, that very tight skin and very painful to pull back. And usually you'll see a lot of discharge coming from there, from the skin or from the opening, and it's coming from their glands. And so they have a not only are they have do they have the balanitis, but then they also have this phimosis, this unretractable foreskin. So these patients need to be seen by a urologist immediately, and they need to be treated immediately. Okay. Hypospadias is another one that's also on your blueprint, but not mentioned briefly in your the current diagnosis book. So this is usually a congenital condition. You're not going to see this a lot in your adult male. Maybe if their hypospadias is more towards the distal tip there, like at the glands. That's a very common one, the top tip there. But generally, this is more for pediatric urology. So usually at birth, they're kind of addressing this right away. So if they have any of the openings kind of basically below the glands and further down, then they're getting worked up. Okay, they're going to be followed. They're going to be followed by pediatric urology for their life or for their pediatric life, and then they're going to be probably seen by an adult urologist, specifically a reconstructive urologist for their adult life. Now, this one is a hydrocele. This is also something that was on the blueprint, but briefly mentioned in your occurrence for like symptoms associated with other conditions. But by definition, a hydrocele is basically a buildup of fluid inside the scrotum. This sac tends to communicate with the peritoneal cavity, so that's why the size can fluctuate, and it can resolve when the guys lay down, and if they were to elevate their scrotum and kind of basically like if they were like how you would prop your feet up for swollen feet. Same thing here with this hydrocele. So if they lay down and they kind of put their scrotum above their thigh and prop it up, then they can get a little bit like most of this fluid back. It just becomes more bothersome because it's gravity dependent, and so it just becomes more pronounced and a little uncomfortable for them to walk, especially if it's hanging and they don't have any supportive clothing to keep their scrotum closer to their body, and so this kind of gets bigger and bigger, and so we can surgically treat this, but until we can close off that communication between the hydrocele and the peritoneal cavity, it'll still keep coming back, and so there is a high fail rate with surgical treatment with these guys. So and they know that when we talk to them about treating it. In non-traumatic cases, we tend to say self-limited and just monitor it. But if it is traumatic cause or it becomes acutely painful, then we will surgically manage this. Okay. Of course, the last one here is other urology conditions. The last one is your testicular torsion. It's on your PANTS blueprint. It wasn't mentioned in your, again, the currents book, maybe a brief mention of it, but just know that any acute sudden pain to the scrotum, which it'll prompt you to order a renal or a scrotal ultrasound. This is something that you have to consider in the back of your mind, especially if it's an acute pain and there was a known trauma associated to the groin or scrotum. And so you have to consider this. On the scrotal ultrasound, it will show poor vascular flow, and also avascular tortuous vessels. So just know that this is a urological emergency and you need to refer them to the ER. Okay. And of course, thank you so much. This is me. I am in the OR and I'm actually holding a prostate. I like I said, I work at Penn. I'm a physician assistant in urology. I predominantly work with my attending. His name is Dr. David Lee, and we operate on men with prostate cancer. So I'm holding a 112 gram prostate, and remember, a normal size prostate is between 25 to 30 grams, and just for a frame of reference of that, it's roughly about the size of a shelled walnut is what they say, or what we say. So yeah, so I wish you guys good luck. And should you have any questions, please feel free to reach out to me. If you would like to shadow me a day in the OR and want to see this and observe, how this what I do, please let your I guess your program director or assistant director Megan know, and I'll be happy to have you in and shadow me. Good luck, guys.